Hello and welcome to this wonderful session of OBS and Gynae. I am Dr. Harmeet Goyal, OBS Gynae faculty. Today I have come up with a very interesting video on the huge demand from the students that I have been taking classes. I have been taking classes for the PG entrance as well as FMG coaching since 2003. Today I am going to take up the topic of mechanism of labor, but before discussing this topic, let me tell you my credentials. I have done my MBBS from Lady Hardinge Medical College, post graduation in OBS and Gynae from VMMC Safdarjung Hospital, Delhi, then hospital management course from National Institute of Health and Family Welfare, Munirka. Then I have completed my senior residency from SDN Hospital and Delhi, and then Metro Group of Hospitals, Noida. Worked as a consultant in various reputed hospitals of Delhi. I am into teaching since 2003. So my passion is basically purely 100%, or I should say 200% teaching. Presently, I am working in the reputed hospital of Delhi, that is Rajiv Gandhi Cancer Institute and Research Center, Rohini. That is number 2 hospital, cancer hospital in India. So my department is the preventive oncology department, where we are more concerned with the screening and how to prevent cancers. So today I have come up with a very interesting video on the mechanism of normal labor. But before I start discussing about the mechanism of normal labor, some of the important topics needs to be discussed beforehand. That is the diameters of the fetal skull, the presenting part presentations of the fetal skull, the attitude, denominator, all of this is very important. What are the sutures, what are the important diameters, what is the transverse diameter of the fetal skull, what are the anteroposterior diameters of the fetal skull, what are the presentations where normal delivery can take place, what are the presentations where normal delivery cannot take place. All this is very important. And the diameters of the maternal pelvis. Once we are through this, then we will talk about the mechanism of labor and in concern with the normal vortex presentation, and I am going to discuss it in this session about the I will show you how the mechanism of labor by using the fetal skull and the dummy pelvis, and the diameters of the fetal skull and the dummy pelvis and the mechanism of labor we will be discussing in the content form, as well as I will be discussing in the presentation form. So let us start with the diameters of the fetal skull. Now this is the frontal bone and the suture between the frontal bones. So when I take classes, I make the things very easier for the students by telling them that imagine my head as the fetal skull. Okay, so here I have been explaining in the 3 ways. I will be explaining on my slides, I will be explaining on my head, and I will be explaining in this fetal skull as well, so that I will make this topic very easier for any student, whether you are a first year MBBS student or a third year or a final year, or you are an intern or your exam going student. This session is going to be helpful for everybody. Now suture between the two frontal bones is the frontal suture, two parietal bones is the sagittal suture, parietal and frontal is the coronal suture, and parietal and occipital is the lambdoid suture. Okay, then in the intrauterine life there are 6 fontanelles. Out of them 4 closes, and when the baby is born, baby has 2 fontanelles. First is the anterior fontanelle, which is called as bregma, and the posterior fontanelle, which is called as lambda. Now in the anterior fontanelle, The boundaries are, it is a star shaped area and the dimensions are 3.2 into 3.2 centimeters, and the boundaries are bounded by frontal suture, sagittal suture and two coronal sutures. Closure of this anterior fontanelle takes place by 18 months of age. So again the boundaries are frontal suture, sagittal suture and two coronal sutures. If you talk about the posterior fontanelle, the boundaries are sagittal suture and two lambdoid sutures. So let us see, this is the anterior fontanelle which is called as the bregma, anterior fontanelle which is called as the bregma. So it is bounded by the frontal sutures, sagittal and two coronal sutures, and the closure occurs by 18 months of age. Posterior fontanelle, which is a triangular shaped area bounded by the sagittal suture and two lambdoid sutures. Its closure occurs at birth. So many times the boundaries of these fontanelles are being asked. Okay, so total number of fontanelles in the intrauterine life are 6. Boundaries of anterior fontanelle, which is bregma, it is 3 into 3 centimeters. So boundaries are frontal suture, coronal suture and lambdoid suture, and closure occurs at 18 months of age. Posterior fontanelle is triangular area 1.2 into 1.2 centimeters bounded by sagittal suture and lambdoid sutures, and closure occurs by birth. If these fontanelles and sutures close early, the condition is called as craniosynostosis. Now, why these sutures and fontanelles are being made so flexible? It helps in the process of molding. Molding occurs in all the deliveries, that is overlapping of sutures and fontanelles over one another in order to provide a smooth vaginal delivery. After the baby is born, these fontanelles and the sutures, they separate out. So it is reversible molding that is been happening. Next is, it helps to accommodate the growing brain. The sutures and fontanelles have been made flexible, that it helps to accommodate the growing brain. Number 3, you can assess the hydration status from these fontanelles. So from this diagram, this is very clear. This is the anterior fontanelle and this is the posterior fontanelle. Now we talk about the transverse diameter of the fetal skull. Transverse diameter of the fetal skull and anteroposterior diameter of the fetal skull, which is very important for us to understand the mechanism of labor. Now, transverse diameter of the fetal skull. If you feel that there are two parietal eminence, okay, so the distance between two parietal eminence, this is called as the biparietal diameter, which at term pregnancy is 9.5 centimeter. If you go down, okay, this is the temporal area and the distance between the two temporal points. This is called as bitemporal diameter, which is 8 centimeter. Then we go on to the mastoid process. This is called as bimastoid diameter, which is 7.5 centimeter. Then there is an oblique diameter, that is super subparietal diameter. Super means above and sub means below. A point above the parietal eminence to a point below the parietal eminence. This is an oblique diameter, which is 8.5 centimeter. So 3 biparietal, bitemporal and bimastoid. These are the transverse diameter of fetal skull, and this is an oblique diameter, which is super subparietal diameter. Now important question or important viva question is, what is the smallest diameter of fetal skull? So for that you need to remember the dimensions, and the answer is bimastoid, which is 7.5 centimeters. So let us just write down. Let me mark these points. So this is the biparietal diameter, which is 9.5 centimeters. This is a very, very important diameter for engagement. I will be describing this process, engagement, in just a short while from now. So biparietal diameter is a very, very important transverse diameter of fetal skull, and this is an important diameter for engagement. Then bitemporal diameter is 8 centimeter, bimastoid is 7.5, and super subparietal is 8.5 centimeters. So if we just draw this, okay, and let us see, this is biparietal diameter, this is bitemporal, and this is bimastoid, and this is super subparietal diameter. So smallest diameter of fetal skull, the answer is bimastoid. The smallest diameter of the fetal skull is the bimastoid diameter. Okay, let us move further. Okay, so these are the transverse diameter which I have just mentioned. So let us just quickly see this in the fetal skull. This is the frontal bone and the suture is the frontal suture. These two are the parietal bones and the suture is the sagittal suture. This is parietal and frontal bones. This is the coronal sutures, and this is parietal and occipital. So these sutures are the lambdoid sutures. So this anterior point here is the anterior fontanelle, and the closure occurs at 18 months. This point, triangular area, is the posterior fontanelle. So I have just discussed that this point, this particular point, is the biparietal diameter. Below that is the bitemporal, and this is the bimastoid diameter. Now let's talk about the presentations. First is, what is attitude? What do you understand by the term attitude? Attitude means the relationship of different fetal parts to each other. So mostly in the intrauterine life, the space is limited. So baby lie in flexed attitude, that the head is flexed, neck is flexed, upper limbs are flexed and lower limbs are flexed. So nature has given it a universal attitude of flexion. Okay, if the attitude of the fetal neck is complete flexion, then vertex is the presentation. Vertex is this whole quadrangular area of my hand bounded by bregma and coronal sutures, lambda and lambdoid sutures, and two imaginary lines from parietal eminence. So vertex is a quadrangular area when the attitude of the fetal neck is complete flexion. The presentation will be vertex. So vertex is bounded by anterior fontanelle and coronal sutures, posteriorly by posterior fontanelle and lambdoid sutures, and two imaginary lines passing from parietal eminence. So this whole area which is shaded, this whole area is the vertex. So this whole area which I have shaded is the vertex. Now there is this particular area of the fetal head is called as the vertex. Okay, this whole area is called as the vertex. Okay, bregma, coronal sutures, lambda, lambdoid sutures, and two imaginary lines from parietal eminence. Now what is denominator? A bony prominence. So in the vertex we take denominator as the occiput to describe the positions. Now if the attitude of the fetal neck is partial extension, this is very important question, because brow is the presentation where the diameter, anteroposterior diameter of the fetal skull is the largest diameter, which is mento-vertical, that is 14 centimeter, and normal delivery will not occur because the diameter of the fetal skull, engaging diameter of the fetal skull is more than the maternal pelvis diameter. Okay, so for that you have to diagnose by the per vaginum examination during the labor, and you have to prepare the patient for emergency cesarean section. Now if the attitude of the fetal neck is partial extension, like my neck is partially extended, then the presentation is brow. Now what are the boundaries of brow? Bounded by the coronal sutures and supraorbital ridges. So this is the brow. Okay, so bounded by bregma and coronal sutures, that is anterior fontanelle and coronal sutures, and here supraorbital ridges. Here is the supraorbital ridges. So this presentation is the brow presentation. Many times there is a question. So this is what is the brow presentation. So many times there is a question on this. Okay, they have given an image and they have asked identify the presentation. So you can see the occiput is posterior, so it cannot be the vertex presentation. Face mentum is again towards one side, so it cannot be the face presentation. So what you see here is this area. So this particular area is the brow presentation. Okay, so attitude of the fetal neck is partial extension. Attitude is the partial extension. Now if the attitude of the fetal neck is complete extension, then the presentation will be the face. Like the attitude of the fetal neck is complete extension, so it is the face. So what are the boundaries of face? Supraorbital ridges and junction of floor of the mouth with neck, and the denominator we take it here is the mentum. So if the attitude is complete extension, it is the face bounded by supraorbital ridges and junction of floor of the mouth with neck. So you can see the boundaries are supraorbital ridges, and junction of floor of the mouth with neck. Junction of floor of the mouth with neck. Now there can be an important question on the type of presentation. So you can see the occiput is behind, this is towards the sacrum side, and you can see the brow presentation is also above. So you can see the supraorbital ridges and chin here. So this is the presentation. So you can mark your answer as face presentation. Okay. So what is face? This particular area is the face. Again, this quadrangular area shaded is the vertex, and the presentation is complete flexion. Delivery is possible because the anteroposterior diameter will be suboccipitobregmatic, which is less than 10.5. In the brow presentation, the engaging diameter is the largest diameter of fetal skull, which is 14 centimeters, and delivery cannot take place. The attitude of the fetal neck is partial extension. So the boundaries are anterior fontanelle and coronal sutures and supraorbital ridges. If the attitude is complete extension, then the presentation is face bounded by supraorbital ridges and junction of floor of the mouth with neck. And what is the denominator? Denominator is the mentum. In the face presentation, again the normal delivery is possible because the engaging diameter will be submentobregmatic, which is 9.5. Submentobregmatic, which is 9.5. So you can see this is complete flexion where vertex and the denominator is occiput, then partial extension. This is the brow presentation, delivery will not occur, and if it is complete extension, then that is the face, delivery can take place. Now we talk about the anteroposterior diameter of the fetal skull. Now there are many diameters, but I have listed here the important three diameters. Important three diameters, that is the diameter, engaging diameter, anteroposterior diameter in vertex presentation. So it will be from, this is occipital protuberance, you take a point below the occiput, that is called as sub. Below means sub and upper means super. So it is from suboccipito to the center point of bregma. So this is the engaging diameter of vertex, that is suboccipitobregmatic, which is 9.5 centimeter. Then you talk about the largest diameter of the fetal skull, which is mentovertical. Mentovertical. From the mentum to the highest point in the vertex, this is brow presentation, and the diameter is 14 centimeters. So the normal delivery cannot take place. It has to be an emergency cesarean section. Then for the face presentation, a point below the occipital, below the mentum to the highest point of bregma. So this is the face presentation and the diameter is 9.5. So there is no difference between the face and the vertex, sub, pragmatic, 9.5, 9.5. The only difference is the denominator. In the vertex, the denominator is occiput. In the face, the denominator is mentum. So this is brow, which is from mentum to the vertex. This is suboccipito-brachmatic, which is the anteroposterior diameter of the vertex, and this is the engaging diameter of face. Okay, submento-brachmatic. So this is mentum to vertex, mentum, from mentum to vertex. So this is mento vertical and presentation is brow. Then vertex is suboccipito-brachmatic, anteroposterior diameter, which is normal delivery can take place because it is 9.5. Then for face, submento-brachmatic, anteroposterior diameters. So this I have completed the transverse diameter. The smallest diameter of the fetal skull is bimastoid and the largest diameter is the mento-vertical. In my subsequent videos, I will be talking in details about the attitude, position, presentation, etc. Now, I talk about very important maneuver that is called as Leopold's maneuver. In every exam, whether it is a practical exam, they ask you that please show this maneuver. This is when we apply the fundal grip, lateral grip, pollic grip and pelvic grip to describe lie and presentations. This maneuver is called as the Leopold's maneuver. So practically when you are in a final year exam, the examiner can ask you to show the 4 grips. Okay. When you are writing a PG entrance exam, they can give you the image and they can ask you the maneuver, or they can give you just one image and they can ask you what is this grip, which they have asked in the AIIMS PG. They have asked about the lateral grip, and in INI CET they have asked about the pollic grip. In the FMG exam again they have asked about the lateral grip. So since 2020 in every exam this question on the Leopold's maneuver is been asked, and it is a very important practical exam question. Now the maneuver is the Leopold's maneuver when you are doing per abdomen examination. So let us see the first grip. The first grip is called as the fundal grip. The second grip is called as the lateral grip. The third grip is called as the pollic grip, which is for the presentation, that is head presenting down, this is called as cephalic. If feet presenting down, that is called as podalic. And the fourth grip is called as the pelvic grip, that is for engagement. Okay. So the first grip is applied when you are doing per abdomen examination. You are standing on the left of the patient with your left hand, you are feeling the fundal grip, and here if you feel hard globular part, that means head is at the fundus. If you feel soft fetal parts, that means it is feet which is at the fundal grip. Then second grip you apply, you feel the fetal back, that is called as the lateral grip. Third grip is facing towards the face of the patient and just opposite, and you are standing here at the feet of the patient. Hard globular part which is ballotable, suggestive of head. So we say it is a cephalic presentation. There is no term as head presentation, it is cephalic presentation. If soft non-ballotable part, then it is called as the podalic or the breech presentation. Fourth grip is, now you are facing towards the feet of the patient. If your fingers are converging, that means head is not engaged. If the fingers are diverging, that means head has gone down into the pelvis. So this is called as the pelvic grip. So again, first grip is called as the fundal grip. Second grip is called as the lateral grip. Third grip is called as the pollic grip, which is cephalic presentation or podalic presentation. And fourth grip is called as the pelvic grip, which is for presentation. So this is important. So first grip fundal, second is lateral, third is pollic, and fourth is the pelvic grip. So this maneuver is the Leopold's maneuver. Next, the presentation, the part of the baby which overlies the lower uterine segment is called as the presentation, which I have just discussed. Cephalic, podalic, or if it is a transverse lie, we say this pelvic grip is empty and we say this is the shoulder presentation or the transverse lie. Now, fundal height is always less than the period of gestation, then you suspect a transverse lie, and abdominal girth is more than the period of gestation, and the pelvic grip is empty. Now, presenting part. When you are doing per vaginum examination, the part which overlies your examining finger or internal os is the presenting part. So, in the cephalic presentation, it can be vertex, it can be brow, or it can be face. Okay, in the breech, it can be the footling or the knee presentation. The denominator, the bony prominence of the presentation used to describe the position. Now we come down quickly to the maternal pelvis. There is a false pelvis which is bounded by anterior abdominal wall, laterally by the iliac fossa and posteriorly by the lumbar vertebra, but our interest is the actual bony pelvis. Okay, our interest is the actual bony pelvis, which is the true pelvis. Okay, so pelvis in our body is not straight, it is slightly tilted forward, so it makes an angle of 55 degrees with the plane. Okay, it makes an angle of 55 degrees with the plane, and the axis pass from the umbilicus to the sacrum posteriorly. So it's making an angle of 55 degrees with the plane. So pelvis, there are 4 levels where we need to know the diameters. There is inlet, which is bounded by upper border of symphysis pubis, pubic crest, pubic tubercle, iliopectineal line, sacroiliac joint and sacral promontory, which is S1 vertebra. This is inlet, okay, and plane of inlet, and you take cut section. There is an anteroposterior diameter, transverse diameter and 2 oblique diameters. Then comes the cavity. So cavity is a segment of pelvis which is bounded by inlet and below by least pelvic dimension. So it's a segment between S1 to S4. Okay, so it's a segment between S1 to S4. So once the baby has passed from the plane of inlet, it comes to lie at cavity. Okay, the diameters of the cavity are taken anteriorly from the midpoint of symphysis pubis and posteriorly at the junction of S2 and S3 vertebra. Now next is the obstetrical outlet, which is a segment of pelvis bounded above by the greatest pelvic dimension, which is anteriorly midpoint of symphysis pubis, posteriorly the S2, S3 vertebra, and below by least pelvic dimension, that is lower border of symphysis pubis, ischial spine, and posteriorly S4, S5 vertebra. So this ischial spine is very, very important in the maternal pelvis. You can see this particular point in the pelvis. This is the ischial spine. So these two are the ischial spine, and the important diameter you can see is the bispinous diameter, because internal rotation of fetal head occurs at ischial spine, deep transverse arrest occurs at ischial spine, levator ani muscle is attached at ischial spine, and pudendal block anesthesia is given at ischial spine. So any diameter less than 10.5 centimeter will deliver. So hence the vertex and face can deliver, and brow cannot deliver, because in the brow the diameter is 14 and this bispinous diameter of the maternal pelvis is 10.5. Then there is anatomical outlet, which is the bony outlet of pelvis, lower border of symphysis pubis, ischial tuberosities and the coccyx. So there are 4 levels: inlet, upper border of symphysis pubis to S1 vertebra, then cavity, which is a segment but the diameters are taken from the midpoint of symphysis pubis to S2 S3 vertebra, then plane of least pelvic dimension, which is obstetrical outlet, anteriorly lower border of symphysis pubis, laterally ischial spine, posteriorly S4 S5, then anatomical outlet, lower border of symphysis pubis, ischial tuberosities and coccyx. Now let us see in our diagram. So this level which I am marking here is the inlet, then next midpoint is the cavity. This is at S1 vertebra, this is S2 S3 vertebra. Then comes the obstetrical outlet, which is at S4 S5, and lateral point is the ischial spine. This is the least pelvic dimension. Once the baby has passed from inlet and it has passed through the cavity does not have any problem because of the greatest pelvic dimension. And then baby comes to lie at the ischial spine, where internal rotation of the fetal head has to take place, and then it is delivered from the outlet. So this bony marking is the anatomical outlet, which is the tip of the coccyx. So if you see the planes, these are the 4 levels where we need to know the diameters. These are the 4 levels where we need to know the diameters: inlet S1, then cavity S2 S3, then obstetrical outlet S4 S5, and anatomical is the tip of the coccyx. So these are the planes: plane of inlet, which is upper border of symphysis pubis posteriorly to S1 vertebra, upper border of symphysis pubis posteriorly to S1 vertebra. Then this area, this shaded area is the cavity. The one which I have shaded with orange is the cavity, which is bounded by inlet and least pelvic dimension, and the diameters of the cavity we take it at the level of S2 S3 vertebra. Then there is obstetrical outlet, which is from the this particular area at the level of ischial spine, and then there is anatomical outlet. Okay, so this obstetrical outlet is S4 S5 and anatomical outlet is the coccyx. So plane of inlet S1, greatest pelvic dimension S2 S3, obstetrical outlet S4 S5 and anatomical outlet at the level of coccyx. So inlet, upper border of symphysis pubis, posteriorly sacral promontory. It has got anteroposterior diameter, transverse and oblique diameter. So you can see this is the inlet, upper border of symphysis pubis, posteriorly to the sacral promontory, that is S1 vertebra. Okay, so this has got anteroposterior diameter, which are called as conjugates. Then there is a transverse diameter, which is the largest diameter of inlet. There was an important question on this. And then there is two oblique diameters. Okay, so anteroposterior is conjugates, then transverse, and then two oblique diameters. Now in the anteroposterior diameter, upper border of symphysis pubis to the sacral promontory, this is true conjugate, which is 11 centimeters. We can't measure. Obstetrical conjugate is from midpoint of symphysis pubis to the sacral promontory, which is 10 centimeter. Then diagonal conjugate, lower border of symphysis pubis to the sacral promontory, which is the largest conjugate of the inlet, and this is the conjugate we can clinically measure. Okay, then the transverse diameter is it is the farthest point on the iliopectineal line, which is 13 centimeters. Then two oblique diameters, left and right, from sacroella of the sacrum to the opposite iliopubic eminence, and these are 12 and 12 centimeters respectively. 12 and 12 centimeters respectively. The most important question is which conjugate you clinically measure. You can see in the image that is the diagonal conjugate. The one which is being measured is the diagonal conjugate, and this is very important viva question as well as the PG entrance question. Identify. You try to touch the sacral promontory, normally you are not able to feel, then you raise your hand till your hand touches the symphysis pubis. So this tip of the middle finger and this marked point is the diagonal conjugate. So anteroposterior diameter, which are the conjugates, transverse diameter and oblique diameters. Then comes to lie the cavity. Cavity is a segment between S1 and below is S4, and the diameter is taken at midpoint of symphysis pubis to S2, S3 vertebra. Okay, and the anteroposterior and transverse diameter at this level is 12 and 12. So in the cavity, the baby has no problem in passing through this level. Then baby comes to lie at the obstetrical outlet. This is very important diameter, because when there is a mechanism of labor, that once the fetal head or occiput touches the pelvic floor at the level of ischial spine, there is internal rotation of the fetal head to 2/8 of a circle. So obstetrical outlet, the important posterior level is S4 and S5 vertebra. So it starts from lower border of symphysis pubis, laterally the point is the ischial spine and posterior point is the S4, S5 vertebra. So lower border of symphysis pubis, laterally ischial spine, posteriorly S4, S5 vertebra. Okay, and the most important diameter at this level is the bispinous diameter, transverse diameter, that is the distance between two ischial spines. Bispinous diameter, that is the distance between two ischial spine. This is very important. okay, and it is, and this is 10.5 centimeters. So for the engaging diameter of the fetal skull, it has to be less than 10.5, then normal delivery can take place. So this is very important. So anteroposterior diameter is from S4 S5 to the lower border of symphysis pubis, which is 11 centimeters. Now, what is the importance of ischial spine? Ischial spine, friends, is called as zero station. Ischial spine is called as zero station. So fetal head descends from -3, -2, -1. Once it reaches the ischial spine, that is zero station, there is internal rotation of the head to 2/8 of a circle, so that occiput lies behind the symphysis pubis. So this particular point is very, very important. So internal rotation of fetal head occurs at ischial spine. Deep transverse arrest occurs in occipito-posterior position at ischial spine. Then levator, you can see in this diagram, levator ani muscle, which is a very important muscle to prevent the genital prolapse. There are three parts of levator ani: pubococcygeus, iliococcygeus and ischio-coccygeus. It's a fan-shaped muscle which prevents the genital prolapse, and this is very, very important muscle when the head is striking at the ischial spine. Because of this coil of these muscle fibers, that there is internal rotation of the fetal head towards anterior, towards symphysis pubis. It does not rotate posteriorly, it rotates anteriorly. And one more important is that pudendal block anesthesia is given at ischial spine. So this is the level where pudendal block anesthesia is given, and the nerve roots that are blocked are S2, 3, 4. This pudendal block is important when you are doing an cervical tear stitching or you are doing an instrumental delivery. So this is important. So importance of the ischial spine: internal rotation of the fetal head occurs, deep transverse arrest occurs, levator ani muscle is attached, and pudendal block anesthesia is given at ischial spine. So last is the anatomical outlet, which is the bony outlet, lower border of symphysis pubis, ischial tuberosities. All of us sit on the ischial tuberosities, and the coccyx. So anteroposterior and transverse diameter are 13 and 11. So this is called as transverse diameter of outlet, and sometimes when we are doing a pelvic assessment, we say 4 knuckles. Okay. So the inlet, cavity, obstetrical outlet and anatomical outlet, these diameters are important, and I will bring my more videos on the fetal skull separately, maternal pelvis separately, normal labor, stages of normal labor, partogram, etc. But today I wanted to discuss the mechanism of labor, so the diameters were very important. So I started the topic with the diameters, and now I come down to the mechanism of normal labor. So friends, labor is said to be normal when it is spontaneous in onset, occurs at term pregnancy without undue prolongation for the stages, and should finish off without any complications. If you are starting an oxytocin drip, that is called as induction of labor. If you are doing ARM, that is called as artificial rupture of membranes, which is augmentation of labor. If you are conducting a delivery in breech, that is called as malpresentation. Normal should be vertex. If you are conducting a delivery in 35 weeks of pregnancy, then that is called as the preterm labor. If the lady is developing the cervical tear or she is developing postpartum hemorrhage or acute inversion, that is called as complicated labor. So labor is said to be normal when it occurs at term pregnancy without undue prolongation and should finish up without any complications, and it should be spontaneous in onset. Stages of labor. The first stage is starting with the uterine contractions and ends with the full dilatation of cervix, which is 12 hours in primary and 6 hours in multi. Average we take it as 8 hours. Second stage is from full dilatation of cervix to the delivery of the baby, okay, and third is the delivery of placenta. Now by the active management of third stage of labor, placental delivery is being conducted by controlled contraction method with the use of a uterotonic drug, that is oxytocin. So no wait and watch policy. Now for the normal labor, remember 3 things. 3 P's are very, very important. 3 P's. Push, passage, passenger. Push, passage, passenger. Push is the uterine contractions. If the contractions are mild, the labor is not going to proceed. You have to augment the labor, okay? And the latent phase may be prolonged or other like problems can take place. So push is very important, uterine contractions. There is an active upper segment which contracts the and it pushes the baby into lower segment, and lower segment just dilates, okay? So oxytocin is responsible for this mechanism. It acts on the uterus and causes contraction. It acts on the cervix and causes cervical dilatation, okay? Then there is a passage. Passage is the maternal pelvis. So pelvis should be adequate. So very important step is pelvic assessment should be done in a primigravida as well as in the multigravida, okay? So there can be a bony obstruction, that is contracted pelvis. There can be soft tissue obstruction like cervical fibroid with pregnancy, ovarian cyst with pregnancy, etc. Okay, and again, not the last one but very important, that is the passenger, which is the fetus. So fetus should be adequate in size. If it is a very good size baby like 4 kg, we call it as macrosomia, and we plan an elective cesarean section, or at earliest indication, if we have given a trial of labor, we can conduct the delivery, okay? So baby size should be adequate towards the pelvis. Then it should not be a conjoined twins, it should not be macrosomia, it should not be fetal ascites, it should not be hydrocephalus. That will cause obstructed labor. So for normal labor, there has to be 3 P's which is important: push, passage and passenger. Push is the uterine contraction, passage is the pelvis, and the passenger is the fetus. Now, mechanism of normal labor, that was our main point or topic of discussion, but these fetal skull diameters and maternal pelvis needs to be revised, and then this topic will become easier for you to understand. Now, in the 2023 exam or 2022 exam, they have asked the sequence of normal labor in INI-CET exam. That is a postgraduate entrance exam. This is very, very important when you're giving a final year exam. They ask you to clinically show the mechanism of normal labor in the dummy pelvis. Sometimes they can ask you about the diameters of the fetal skull or maternal pelvis. So this video is going to be helpful. Whatever exam you are aiming, whether you're preparing for Viva in the final year, or you're studying, or you are writing a PG entrance exam. So I've tried to cover up maximum points in this one video. I will bring up more interesting subsequent videos in the near future. Okay. Now, engagement. Okay, the terms in the obstetrics are very, very misleading. But what is the term engagement? Engagement means when the largest diameter of the fetal skull has crossed the pelvic rim or plane of inlet, or when the largest diameter of the fetal head fits into the largest diameter of maternal pelvis, that is called as the engagement, that no fetal poles are felt in the in the abdomen. It has entered into the pelvis. Okay, so that is called as the engagement. In primigravida, engagement occurs at term pregnancy, whereas in multigravida it occurs later. Okay, so in this figure, this is shown the inlet. This particular part is the inlet and baby's poles have crossed. If you see 5 fingers including the thumb and in the per abdomen examination, and all the parts of the baby are felt in the abdomen, then we say head is free floating and fetal head is not engaged. We can do it with the Leopold's maneuver, that is the 4th maneuver, pelvic grip, or we can do by the finger method, that is rule of 5. When you can see in the symphysis pubis, only above that there is 2 fingers felt. That means 3 poles of the baby has gone into the pelvis and it is 2 by 5. If you can just feel 1 finger and all the 4 fetal poles have gone inside, then you say 1 by 5. And when there is no pole felt, then you say 0 by 5. So head is deeply engaged, 1 by 5 head is engaged. Okay, so this is what is important. So it is the biparietal diameter which is very, very important, transverse diameter. When it has crossed the pelvic brim, it has gone down, and no fetal poles. That is, we divide the fetal head as the 5 poles, and we can say if all the 5 fingers are felt in the above the symphysis pubis, then we say head is free floating and it is not engaged. Okay, so this is something which is very, very important. So if you see like this and you see the head has gone down like this and no part is felt, then we say the fetal head has got engaged. Fetal head has got engaged. So if you say the descent of the fetal head from -3, -2, -1, 0, this is called as the descent. So 5 by 5, when all the 5 fingers are felt above the symphysis pubis, that no pole has gone down, so we say 5 by 5. Then one pole, we feel 4 fingers, 4 by 5, 3 by 5, 2 by 5, 1 by 5, 0 by 5. So when we say 2 by 5, that means it is just engaged. We say 1 by 5, it has got engaged, and 0 by 5, no pole is palpable, then head is said to be deeply engaged. This is very favorite sign that it rules out CPD, it rules out deflexed head. Okay, so this is free floating, this is on the brim, this is not engaged. 2 by 5 is just engaged, 1 by 5 is engaged, and 0 by 5 is deeply engaged. So this is what is shown, the descent of the fetal head, and ischial spine is called as the 0 station because internal rotation of fetal head occurs at the level of ischial spine. +2 station is again very important. So in the instrumental delivery, the outlet forceps you apply at this level, and between 0 to +2 you can apply the vacuum extraction. Okay, so 0 station very, very important because internal rotation occurs during the mechanism of labor, and this is the level. Below that +2 you apply the outlet forceps in instrumental delivery. So this is called as the descent. In primigravida, engagement occurs before the onset of labor. In multigravida, it occurs late in labor. So free floating fetal head, it is not engaged. What is the important reason? So most important reason is the deflexed head and CPD, cephalopelvic disproportion. You can see that the neck is very well flexed, that is vertex, and this is what is a deflex. Now why the possibility of delivery is not there? Because I told you that the bispinous diameter where internal rotation occurs is 10.5. So fetal presenting part, the engaging diameter has to be less than 10.5. So hence Brow will not deliver, deflexed head will not deliver, but the face and the vertex will deliver because their diameter is 9.5. In brow it is 14, it will not deliver. So that is partial extension, and in deflexed head it is 11.5 centimeters. So deflexed head and CPD has to be ruled out, and in the presentation brow has to be ruled out, okay, for this non-progress of labor. Now in the maternal pelvis I will be just explaining the mechanism of labor in context with the vertex presentation. So I will take up left occipito-transverse position. So if I am showing the pelvis, like this. So this is the left side, okay. This will be the left side and this is the right side, okay. If the mother is like this, then this will be the left side of the mother and this is the right side of the mother. So if I am showing this, this will be the left side and this is the right side, okay, of the pelvis. So these are the positions which is shown: LOT, ROT, that is left occipito-transverse, and the right occipito-transverse. This is occipito-anterior, right and left, and these are the posterior positions. So I will be explaining the mechanism of vertex presentation and delivery in context with left occipito-transverse. So I will be explaining according to this. That means occiput is towards the left side, okay. Occiput is towards the left side, fine. So you can see these are the important presentations. These are the 6: left occipito-transverse, right occipito-transverse, left occipito-anterior, right, and similarly the posterior. So many times in your exams, when you're writing the PG entrance exam, these images are being asked very commonly, okay. So how to detect? Imagine that the pregnant lady is lying in front of you. So this will be the left side of your patient. So you can see occiput is placed towards left side and in the oblique diameter. So you can mark your answer as LOA, and occiput is placed towards right side in the oblique diameter, so it is ROA. If it is placed, like you can see, it is in the transverse diameter, the sagittal suture is in the bispinous diameter, so it is left occipito-transverse, and here it is occiput is right, okay. And if it is placed towards the sacrum, then that is the posterior presentations. So this is the occiput. So I am talking about left occipito-transverse. Let's quickly revise. In the exam INI CET, there was a question in 2022 exam. There was a question on the sequence of normal labor. So there is engagement. Engagement I have just explained. Engagement, descent, flexion. So after the engagement, descent and flexion is occurring, and the main feature responsible is the uterine contractions and later on bearing down efforts of the mother. So descent and flexion occurs simultaneously. Then there is internal rotation of the fetal head to 2/8 of a circle, so that the occiput comes to lie behind the symphysis pubis. Then there is so much of torsion in the fetal neck, and fetal neck cannot sustain torsion. So shoulders rotate and it comes to lie in the oblique diameter. Then 1/8 torsion in the neck is still left. Then occiput stretches the perineal outlet. This is called as crowning, when the fetal head comes and do not go back. And then head in the intrauterine life was in flexion. So head is borne by extension. Okay. So first there is delivery of the occiput, vertex, brow and face. Then there is dropping of the fetal head towards the maternal perineum. This is called as restitution. Then there is external rotation of the fetal head towards the left of the mother. Okay, this is to untwist the neck, and when there is external rotation of the fetal head. The shoulders were in the oblique diameter, so any part of the baby, it will has to come in the anteroposterior diameter, only then delivery will occur. So from the oblique diameter, when there is an external rotation of the fetal head, then there is internal rotation of the shoulders, so that shoulders lie in the anteroposterior diameter and rest of the body is delivered by lateral flexion. So engagement, descent flexion is occurring together. It occurs by the uterine contractions because there is a push towards the lower uterine segment, and later on by the bearing down efforts of the mother. Then there is occiput touches the pelvic floor at the level of ischial spine. Then there is levator ani muscle. Because of the coil of the levator ani muscle, there is anterior rotation 2/8 of a circle of the fetal head, because any part of the baby which has to deliver, it has to lie in the anteroposterior diameter. So the denominator lies in the anteroposterior diameter. That means the sagittal suture lies behind the symphysis pubis in the anteroposterior diameter. So simultaneously there is 1/8 of a circle internal rotation of the shoulders because it has to untwist the fetal neck. Then head stretches the perineal outlet, which is called as crowning, means the head comes and do not go back. Then the head is borne by extension, because in the intrauterine life and during the birth canal it was completely flexed in order to be accommodated in the birth canal. So head is borne by extension where first part to deliver. This is very important Viva question. The students, please remember this. First of all, the comes out part is the occiput, then the brow, then the face, and then the mentum. Okay. Then head droops down towards maternal perineum. This is restitution. Okay. Then there is external rotation of the fetal head. Because the shoulders are in the oblique diameter, so shoulders have to rotate and comes to lie in the anteroposterior diameter, and rest of the body is delivered by lateral flexion. So again let's see, and then I will be explaining with dummy pelvis. So first of all, the head is engaged. Engagement is when the major diameter has crossed the pelvic brim. Okay. Descent and flexion is maintained by uterine contractions, and later by maternal bearing down efforts. So first is engagement, second is the descent and flexion occurring together. Then there is internal rotation. Internal rotation is occurring at the level of ischial spine when the occiput touches the pelvic floor. This is called as zero station, and the bispinous diameter is 10.5. So engaging fetal skull diameter has to be less than 10.5. That is why the delivery can occur easily in the occipito-transverse or in the occipito-anterior positions, okay, where the engaging diameter is 9.5, suboccipito-pragmatic. In the face presentation, again, the anterior positions can deliver easily because the diameter is 9.5, okay. Then there is crowning, and head is borne by extension. Head is borne by extension. First of all, the occiput will deliver, followed by brow, followed by face and mentum, and rest of the body will be delivered by lateral flexion. Okay. Then at ischial spine, the internal rotation occurs to 2/8 of a circle, and it rotates anteriorly. Why? Here you have to know the Hart's rule. What is that? Because they can ask you in the Viva or they can ask you in the MCQs. Levator ani muscle is inclined towards the midline and elastic recoil of the levator ani muscle. That's a big muscle which is attached from symphysis pubis to the ischial spine to the coccyx, and it is a fan shaped muscle that prevents genital prolapse. In gynae and in obs, it is very important for internal rotation to take place. Okay, so occiput rotates anteriorly because of this levator ani muscle which is inclined towards midline, and there is an elastic recoil of this pelvic floor muscles. So rotation of the head, then there is shoulders also rotate 1/8 of a circle in the same direction. Okay, and head is delivered by extension. First is occiput, brow, and then face will deliver. The external rotation of the head occurs simultaneously. There is internal rotation of the head, and they come to lie in the anteroposterior diameter, and then rest of the body of the baby is delivered by lateral flexion. Okay, so this is delivery of the anterior shoulder first, and followed by delivery of the posterior shoulder, and rest of the body is being delivered. Now let us see the mechanism of labor simultaneously in this dummy pelvis. The diameters I have already discussed